depending where you're joining from. My name is Ayman Al-Jurdi, and I'm moderating the Glomerular transplant sessions. And we're very lucky today to have with us Dr. Tariq Elhamad, who's joining us from WashU, St. Louis.
Thank you so much for the nice introduction, Dr. Al-Jurdi. It's my pleasure to be with you today. It's 10 a.m. at my time, also Central Time. We'll talk about, as Dr. Al-Jurdi, we'll talk about one option of kidney transplantations, about using kidney from hepatitis C. Alrighty. I don't have a specific conflict of interest with any of the pharma company with the Hep C. I have received a prior grant from Mid-America Transplant to look at the outcomes with the Hep C donors. This is the outline of my presentation. We'll talk about a little bit about the prior practice of the use of interferon for Hep C treatment, about the kidney allocation and the Hep C shortage of organs, DAA therapy outcomes, and the current practice of Hep C positive donors. In the old way of treating hepatitis C, the system was based, or the treatment was based on using interferon. Interferon was indirect antiviral therapy. It's usually used with combination with other treatments. It inhibits Hep C replication indirectly and also plays a role in modulating an immune response against hepatocytes infected with Hep C. However, interferon has some issues. Overall, it's not very well tolerated. Have issues with 20% of patients have issues with tolerability, in addition to low efficacy in genotype type 1, which is the most common type of Hep C in the United States. When we have a donor with Hep C positive viremia, we are expecting that the transmission of the virus will be almost 100% to the recipients. So at the time of the interferon, all these patients will receive interferon therapy. Now, in addition to the overall side effects, interferon comes with specific side effects to the kidney, and any kidney, and in specific to the kidney transplant, including kidney injury, association with GN such as MPGN. It has been linked with a lower graft loss compared to the patients who don't have Hep C, high rate of Hep C relapse in the recipients, and with chronic liver disease. And in terms of rejection, which is quite specific for the transplant recipients, there have been several studies actually talking about that at the time when interferon was used. The exact mechanism are not very well known, but the two theories have been shared about the etiology for rejection, including enhanced expressions of class 1, HLA class 1, class 2. So it increased the recognition between the antigen-presenting cells and lymphocytes. In addition, it plays a role in the T cell activation. And just FYI, both CNIs, cyclosporin and tacrolimus, inhibit interferon production. Putting that in our mind, putting that increased risk of rejection, lower graft survival, not many transplant centers were utilizing Hep C donors unless the recipient have already Hep C and he had not received the treatment. So the Hep C kidneys had quite high level of discard. The system was based on, the system of the allocation in the US was based on a binary system. It used to be either standard kidney or extended criteria kidney. So either a good kidney or not a good kidney. Extended criteria was based on either the age more than 60 or the age more than 50 with 2 out of 3, hypertension, CVA, or creatinine more than 1.5. And then there was a new allocation system that is more as a continuous score that is based on 10 factors. This include age, BMI as divided by height and weight, race. African American donors tend to have, the kidneys from African American donors tend to have lower graft survival, compared to white and Asian kidneys or Asian donors, hypertension, diabetes.